Okay, so I hope everyone is well fed and enjoyed this evening's dinner, and we had the opportunity to socialize and get to know each other. We're going to move on with tonight's program. To start off this night's program, I'd like to introduce Chief Zaludik, Fire Chief of Eugene Springfield Fire.
Thank you, Chris. Welcome. We're so thankful to have you here today. This is an opportunity that we thought about a few years ago. We had the opportunity to have the resources available to do this, and we just said one day it's a good idea, and Rachel, our executive assistant, took care of everything from there. I just want to give Rachel a quick round of applause for the work she did, transforming this classroom into a very elegant evening. Thank you, Rachel. Cardiac arrest is a challenge that we have struggled with for years. You're going to hear a lot about how things have happened throughout history, but what we can tell you is there were some visionaries in this community, a couple are in this room, that about in 2011 listened to what the data was saying and started making decisions for this community that has positioned us where we are today. And you're going to hear about a lot of people that have done a lot of things to improve this outcome. But one of the visionaries is here in the room with us. And Dr. Munkenbeck, could you just raise your hand just quickly? Thank you, Doctor. I don't know if you remember this. I was in a meeting with you around 2011, and I saw the passion, and you rallied members of the team and talked about what it would take to improve our cardiac arrest survivals to compete with some of the best in the country. And at the time, I wasn't sure how these pieces of the puzzle were going to come together, but it took a vision and dedication and commitment. And there were a couple of doctors that helped with that, but I know that you were part of the lead and the inspiration for getting that done. And I want to also point out Josh Moore, who's here. Could you raise your hand real quick, Josh? Josh had the opportunity to be on light duty at about the time we were starting this project. And he said he thought he could help. I asked him what experience he had. He said he was a project manager in the past, and I'm going to tell you, he is a project manager. He's a starter. He's a finisher. He did a magnificent job at making sure this progressed to where it had to come. Lots of people contributed. I just wanted to make sure I didn't miss those 2 points as we start out today. We do want to honor all of our survivors of cardiac arrest today. With that being said, many people that had this experience were not willing or quite yet able to have the discussions and relive some of these experiences that they had with their event. Today is about healing. This evening is about healing. If for any reason you or your family members need to step out and compose yourself, or it's not something you're prepared to listen to now, we encourage you to do that. This is meant to be a part of your healing and recovery journey that you're able to share some of this. We're very appreciative for the people that did share some of the videos you're going to see today. But some of our survivors were uncomfortable in person. They were able to do it on video. We're very thankful for them. We're very thankful for the courage that you show coming here today. And I just want to take this opportunity to say that if anything comes up where you think you need to visit with a professional, contact me or Rachel or one of our team members in the room, and we'll make sure we connect you with a professional that'll help with that part of your journey. So these things are emotions are connected to experiences, and we just want to make sure that we don't put anybody in a position where they're uncomfortable on an evening that we're trying to celebrate, the survival. Before I turn this back over to Chief Heppel, and he's going to kick off the chain of survival discussion today, I just wanted to talk about a little bit about the people, not just Josh and Dr. Munkenbeck. If anybody in this room has participated in changing our response model to the point to where we're doing the hands-only compressions today, whether it's policy, whether it's training, whether it's in the 911 center, retraining how we dispatch. 30 years ago, we used to dispatch an engine company of 3 people and a medic unit of 2 people, and we would do CPR in that fashion. Today, what you're going to hear in the chain of survival, that there's no less than 9, usually 10, 11, or 12 people that continue that care if we have to, especially if to move somebody up and down stairs. So if you have participated in any manner of changing our policies to get us from where we were around 10 to 12% to where we are now, hovering around 50%, which is in competition with the best in the world, please raise your hand if you've participated in any of this. And that includes training. I know I see some people in training that have done this. Thank you. Thank you, Cynthia. Yes, it is a true team effort. And I just want to thank the members of the team, and I want to thank the department members that have come here today to listen and share, and we really just appreciate your efforts. With that, I'd like to turn it over to Deputy Chief Chris Heppel so we can start the chain of survival tonight. Thank you, Chief.
I think to tell any story, we would be remiss but not to look at a little bit of history as to the chain of survival and resuscitation efforts. As I said earlier, we're talking about centuries of efforts in thought of what makes someone come back from life and actually have a resuscitation attempt. You know, the first chain or link in the chain of survival, if you reference your cards, is that recognition and calling 911. And it was back in the 1960s in which a presidential commission with actually law enforcement designated and said, you know what, in our country, we recognize that there needs to be a single access point for people to get emergency help. Certainly we're not going to credit law enforcement with that tonight. We'll just say it was a law enforcement commission that did that in the end. But it certainly has made strides, especially when you consider the ability back then of everything had to be done with literally a 7-digit number, and you try and remember those numbers, and even having access to phones. I certainly remember growing up in Glendale, Oregon in the 70s, and we still had a party line and a 7-digit number in Douglas County, and it was 3 different numbers for the ambulance, for the fire department, and the sheriff's department. So we've truly come a long ways when it comes to that. The next link in the chain of survival is compressions. The first efforts of compressions were actually flogging. We saw this around 800 or 900 AD, and the thought process is that essentially you would stimulate the person back to life or bring their soul back in the end. The next was bellows. While we joke about this, this was actually a medical procedure back in the day to actually use the same bellows in which you would give air to your fire or stoke your fire with, the concept being we're going to help that person breathe for them. The next effort we saw was the vertical resuscitation technique. I actually was like, wow, is this for real? And I looked at it on the AHA website, the American Heart Association website, and it's like, yeah, this is actually a practice technique in medieval times with an effort to try and move air in and out of a patient. The next attempt was the barrel method, and the thought process was, someone could be rolled across on a barrel to stimulate movement of air in and out of them, again, in an effort to resuscitate them. While that technique did not prove to be accurate, the next technique was, well, what if we put a strap around somebody and we pull on it at the same time in an effort to compress the chest, and then we release it and allows air to go in and out. Again, an unsuccessful effort in that category. And the third one was the equestrian method, in which we would throw them onto a horse. We would allow the bouncing of the horse to actually stimulate air going in and out, which actually isn't too far from the truth when you think about the passive ventilation we do today with compressions. Just maybe the right idea, poor execution. We actually moved on, and this is actually in the 20s. We saw more of a massage technique. If you actually Google resuscitation or the history of resuscitation, you'll actually see these from lifeguards attempting to resuscitate patients who had been drowned in an effort to get the water out and air moving in and out of their patients. Technology continued to move on, and it was in the 1950s that it was actually Dr. James Elm who in 1954 recognized that expired air, so air in which we blow out or expire out, could actually sustain life. And from that, just 2 years later, it was actually Dr. Safar in 1956 who came up with the procedure of mouth-to-mouth resuscitation as we know it. In 1957, just a year later, the U.S. military adopted that as a standard within the organization. And then only a few years later, in 1960, did we actually see the first generation of CPR, or the forerunner of what we thought it would be. The American Heart Association actually started to adopt this process, formalized a committee, and then that's what was utilized to train surgeons to help with resuscitation. Again, it was absolutely a forerunner to modern day cardiopulmonary resuscitation. So with that, what's our third link? Anybody, just scream it out. I gave you a card. Defibrillation, excellent, excellent. Defibrillation, so a lot of credit for the defibrillation, especially out of the field, or what we refer to as pre-hospital defibrillation, went to Dr. Frank Patronage. That's him pictured in the upper left-hand corner with his first-generation defibrillation machine. He would also go on to develop the first mobile coronary units, and that concept of actually transporting patients with coronary problems and issues to a hospital. But ironically, it was, not ironically, it just was, it was in 1967 in Belfast, Ireland, where we saw the actual first out-of-hospital cardiac arrest defibrillation with a successful outcome. So these pieces really move back and forth around the world when we see, as we've seen the development and the different pieces starting to come together. Certainly with this, did we do CPR with defibrillation? Not really, that hadn't quite all been there yet. 911, again, was just coming on, so we're talking the late 1960s. A lot of these ideas were all coming out of, many of them out of the Vietnam War. So Vietnam War was also telling us that we needed to get patients to definitive care. It was in 1966 where a landmark document, which is referred to as the White Paper in EMS, which is the true title was The Death and Dying in Our Streets, documented that, you know what, over 50,000 people a year were dying on our highways from motor vehicle collisions. And it was that document which stimulated the Department of Transportation to develop our emergency medical systems today. So it was that late 60s time frame where we saw CPR was coming around, but only doctors were really trained in it at this point, maybe some nurses. We saw the 911 system came around. However, it hadn't been implemented nationwide or utilized the way we use it today. We saw our first field defibrillation, but I could tell you that they were not using Dr. Safar's portable unit. It was a pretty large unit in the back of that mobile van. And then we started seeing, how are we going to roll this out into the streets? So who do we give credit to for those first EMTs? Typically, this is where we go, because this is what we knew. So, it was in 1970s down in Los Angeles where the Townsend-Wadsworth Act was actually written in and allowed for paramedics to be created. However, the true first team was actually given credit to this group. Dr. Safar, again, who I mentioned before, who would move on to be a landmark emergency physician, said, you know what? We need to start getting the people out in the field. So we actually implemented this program here, and it was in Pittsburgh, Pennsylvania, in around 1967, 68, where he actually utilized unemployed African-American men, brought them together and said, you know what, you guys are going to go out and do this work. And they were referred to as the Freedom House Enterprise or Freedom House Ambulance Service in Pittsburgh. It was then in 1970 that I think LA kind of stole the idea, and they started the paramedic programs. And then simultaneously in the 1970s, we saw other paramedic programs start to develop, St. Petersburg as well as in Seattle. And even paramedicine started its early roots here in Oregon. It was actually Dr. Rose in Portland, Oregon, in combination with an agency called Buck Ambulance, who started one of the first 5 recognized paramedic programs in the United States. So Oregon has a lot of history embedded with that. We would know Buck Ambulance today as American Medical Response. Certainly moving forward with today, we've made a lot of strides and headways with combining pre-hospital care, early defibrillation, CPR, advanced cardiac life support, and then there were certainly advancements when it came to the emergency room and catheterization labs, which we're going to see today. So first I'm going to start with the recognition and activation of the emergency response system, and we commonly refer to that as 911. So I'd like to introduce Cynthia Ultimus, who is a communications center supervisor, to come on up and talk to us about 911. Want this up here?
Thank you, Chris. So did any of you notice the anniversary of 911 was last week? We are 50 years old, and the first 911 call was made in Alabama. The second one was made 4 days later in Alaska. So 911 has long roots in the nation, and in Oregon it's border to border since the early 1980s. So any phone in Oregon could access 911 starting in the early 80s, which is pretty cool. We've come a long way in what we're able to do at 911 with early recognition and initiation of responses. Our role is to care for the citizens and visitors of Lane County when something goes terribly wrong. And this day and age of cynicism and divide, people know they can trust that when they call 911, they're going to get an incredibly caring professional who's well-trained, who can get the system started for them. So we're triaging in a non-visual environment. We're hearing what our callers are telling us is going on. We're interpreting what they're saying. And then while we're having dispatchers get help on the way and get the responders to the scene, we're providing care for the patients until somebody can get there. And we're putting it back in the hands of the caller by giving them very specific instructions about how can you help your coworker, your friend, a stranger, a loved one. So the realm of emotions and surprise that comes up in these calls is pretty amazing, and we're navigating that whole thing so our goal can be met of getting hands on chest in 60 seconds when somebody has a sudden cardiac arrest. So when I started in the profession 20 years ago, we made sure somebody was good and in need of help before we did very much. We laid them on their back, we did a pulse check, we did a pulse check, we did a pulse check, we made sure there was no pulse, and then we made sure there was no sign of breathing before we ever started compressions because we were concerned about hurting patients. Today, if somebody isn't sure somebody is breathing, we take that as they're not breathing, and we try to initiate hands on chest compressions within 60 seconds. And that is why we have survivors in this room today, is it's that first vital link in the chain of survival. So we would do 15 compressions and 1 breath. Now we do 600 compressions before we give a breath because we need that circulation to be going so that people can be defibrillated, so they can be resuscitated, so that they can go on with a great quality of life after this incredible event. So we have a very incredible staff at 911. Several of them are in the back here. We are the first responder, and we're really honored to serve this community. Thank you for letting us be part of this tonight.
Thanks, Cynthia. Moving forward, immediate high-quality CPR. Cynthia has already alluded to that as how we really try and push that forward through the 911 system, through information passed on through the phone system. I certainly remember my first CPR class back in the day. Probably what is most traumatic was the whole landmarking of the chest, where you had to follow the rib line, locate the xiphoid process, measure twice, and then subtract 1, and then it was somewhere in here, and you would fail if you didn't get proper hand placement. It was pretty amazing. And nowadays we've recognized, you know what aren't we doing? And that's compressions when we're doing those things. So next, with the high-quality CPR and its impact, as well as our system, I'm going to go ahead and bring up Josh Moore, who is our subject matter expert on this topic.
Thank you, Chief. This is a dream come true to me tonight. When I started working on this project, one of the daydreams that I would have is think what it's like to sit in a room with survivors and all the people that had a hand in that chain of survival, because every single link in that chain on that card is vitally important. And if any one of those links in that chain of survival is broken, people don't survive. And I'm going to start with telling you about the first time I ever did CPR. I was on vacation in Mexico. I was in the military, and we were on a surf trip, and we pulled somebody out of the surf that had drowned. And all I knew about medicine at that time was how to do compression and mouth-to-mouth CPR. So me and a couple buddies started doing mouth-to-mouth compression CPR on this person. And after about 15 minutes, the paramedicos showed up, and they did one of the strange things like you saw on the slide. One of the first things they did is take a knife, and they slit open the bottom of that person's foot. It didn't do anything to help their resuscitation, and the person actually expired. But I remember thinking, boy, that's really odd. And for over the centuries, and even over the last 100 years, a lot of what we did in resuscitation wasn't based on good science. We were really focusing on the wrong organ. We applied electrical shocks to sensitive parts. We used fire bellows. We sliced open the bottom of people's feet. None of that stuff was actually helping people survive. Even in 1962, when we started formalizing how to do compression and mouth-to-mouth CPR, we didn't see a bump in that survival anywhere. It averaged about 10% throughout the nation, and some places only had a 0% chance of surviving cardiac arrest. And the problem is because we were working on a lot of individual links in that chain of survival, but we weren't putting the whole chain together. And there were too many broken links, and people weren't surviving. So sudden cardiac arrest is obviously a brain problem. When you don't survive cardiac arrest, it's because your brain tissue is expired. It's not a heart muscle problem. The heart's just a muscle. But for every minute that goes by that your brain doesn't have that blood flow, you lose about 10% of your brain function. And so it's really important that we supply chest compressions to keep that blood flowing through the brain, to keep that brain tissue alive. And so every one of these links, the early recognition, the early access to 911, the instant chest compressions, the early defibrillation, the advanced cardiac care, the transport, all of that is, we still have to maintain that person's perfusion of the brain cells throughout that transport. So it's a community approach. It's not just any one of our groups. We have cardiologists, we have paramedics, we have survivors, we have 911 dispatchers, we have administrators. Everybody's got a vital part in that chain of survival, and I just appreciate everybody that's here and the work that you've done to make our survival what it is now. I don't know if you know this, we were at 12% in 2011. Later tonight we're going to announce what we were last year, and we are matching the best in the country, and it's because of all of you. All of you have a big part in that, and I thank you. The next thing I just want to mention, early defibrillation is also vitally important. We do look at the number of times AEDs are applied by lay people out in the public, and if that AED is used, 80% of the time it's successful in converting that person to a perfusing rhythm before we ever get there. So chest compressions are certainly the foundation of that person's resuscitation, but AED and advanced early defibrillation is also vitally important. We're happy as paramedics to apply that electricity, but you have access to an AED, certainly use it, because 80% of the time it's effective before we get there. I want to next read a quote by Craig Amon. He was a fire lieutenant that worked for Seattle and brought us up to the Resuscitation Academy and helped us make a lot of the changes that we made here to be successful. And what he said when we started talking about what we want to do down here, he mentioned this quote. Find it for you. If we can get people to recognize cardiac arrest, perform CPR, call 911, then our survival of sudden cardiac arrest will improve. It sounds really simple, but until you link all those chains of survival together, people weren't surviving. And in fact, we actually kind of got a slow start. Our first year our survival was a little bit lower, and then each year we've just stair-stepped in this last year. I'm pretty proud of the result we're about to announce here. So specifically, what we've done with the ACT-C3 program, which is the program that I still work on that aims at improving cardiac arrest survival in our community. With the help of Alpha Phi Sorority, we brought 4 members from Alpha Phi. Stand up or raise your hand. What we do is we go out to basically anybody in our community that requests access. We offer free training in compression-only CPR, and we've trained about 6,000 people in the public now how to perform compression-only CPR. We've also traveled up to the Capitol and met with lobbyists and got a Senate Bill 275 sign that says by the time a student graduates high school in Oregon, they will have been trained in compression-only CPR. What that does, that adds about 40,000 people, 40,000 first responders every year that know how to recognize cardiac arrest and what to do, and that should raise our rates of survival. We've done many news articles, radio ads, banners on the back of buses, and KVAL has filmed a commercial that they air telling people, hey, don't be afraid to start chest compressions. Hard and fast chest compressions save lives. We've certainly changed the 911 dispatch focus. We're on the chest in less than 90 seconds, which is great. And we adopted the best practices in advanced cardiac life support that's out there really in the country, and we've brought it here to Eugene. And then we continue to monitor all the metrics. We capture all the data from every single cardiac arrest. We enter it in the CARES registry, and then we look for areas of improvement or to see what we're doing right. The last time it was analyzed state by state as far as cardiac arrest survival, it was in 2002, and Oregon was the 5th worst place in the country to survive cardiac arrest. And this community is helping change that. That's not the case anymore, and I think next we're going to get ready to talk about the next phase of how to get the public involved in responding to cardiac arrest and what our latest survival is. So I'm going to introduce the EMS Chief, Joanna Campy. If you'd like to come up and do the next exciting part of this. Thank you.
Hi, thank you, Josh. It's really an honor to be in your company tonight, and we are celebrating survival, and it is with great vision that we're here today. And last year when we reached our cardiac survival rate of 50%, I sat in my office and I just cried. I was so happy, and I couldn't believe it that we had actually done it, that we had met our goal in 4 years of what we had said would probably take us 10. And in other communities had taken us that long as well, or had taken them that long. And I thought, oh my gosh, it just tells me what we can do when we work together as a collaborative group to enhance the survival of cardiac arrest. And really that when we work together from our 911 dispatchers and every piece of the chain of survival, and we sat and we had multiple meetings about how we could make things better here. And we entered our data into the CARES registry, and this year our survival rate is also 50%. And the part that's really amazing about that is that bystander CPR dropped from 63.6% in 2016 to 51.9% in 2017. So it was almost a 12% decline in bystander CPR, but we still maintained a survival rate of 50%. So that really speaks highly to how strong our chain of survival is in this community and what we're able to do without the strong bystander CPR link. So we're looking at how we can enhance that to make that better in our community. And we're really fortunate to have been partners with Peace Health Foundation, Mackenzie Willamette Hospital, and the Region 5 Training Association that helped bring PulsePoint to this community. We've been talking about PulsePoint for almost 2 years of how we could get PulsePoint to our community. And through the help of our strong partners, we're able to do that. PulsePoint is a software that is an application that can be downloaded onto a smartphone that alerts people in the community to when there is a cardiac arrest event in a public place, and it alerts to where the closest AED is as well. I have a short video clip to show you how that works. Hopefully this will run.
This is Joel. He just suffered a sudden cardiac arrest. He isn't the only one. Today, 1,000 people in the United States will have the same experience. Time is now critical. As a call is placed to emergency dispatch, the clock continues to tick. Emergency responders are several minutes away. Unfortunately, several minutes can be too long. For every minute Joel goes unaided, his chance of survival decreases by 10%. Fortunately, Joel lives in a PulsePoint connected community. PulsePoint is integrated with his community's emergency dispatch. The moment Joel's emergency call came in, a PulsePoint alert went out, connecting nearby CPR-trained volunteers and AEDs to his location. Meet Scott, an off-duty firefighter out running errands, and Donna, a financial planner working next door. Because they were nearby and quickly alerted, they're now able to provide life-saving care until emergency responders arrive. That initial care made all the difference. This is Joel. He's a sudden cardiac arrest survivor. Armed with Pulse Point, any volunteer can help save a life. Become a life-saving volunteer and download Pulse Point today.
So we're just in the starting process of this. We still probably have about 6 to 8 weeks left to go before this will be active in our community, but it is right on the horizon. And with that, we will have hopefully more bystanders and more responders to help us in our community to enhance this link in the chain of survival. Chief Hubble?
Thanks, Joanna. So leveraging technology is certainly something we want to do, not only reaching out to the public, but also doing that with the advancements in our advanced life support capabilities and equipment. And we'll be seeing more of that as we move forward into the future. Another program that we're implementing with Peace Health, which should be rolling out hopefully by June, is a program called Pulsera. And our goal with that is to have early notification to the hospital, earlier and faster notification to the hospital that we're bringing these patients in. It's currently fielded at Peace Health facility in Vancouver. Talking with the medics up there, they've personally said it has sped up time to transition from the apparatus bay up into the cath lab, which we'll see some photos of that here in a little bit, up towards of minutes. And as we've seen, time is precious when it comes to these incidents. So let's go ahead and watch a video.
My name's Melissa Houston. I like to share my story and also interact with other people because everybody has their own story. But it's interesting to see what things you do have in common. I have had these, issues off and on through my adulthood, but I never thought that I would have had a heart attack or a cardiac arrest. I thought of everything else, but I just couldn't see myself having one of those events. I don't know why. That morning I had gotten up and got ready, and I remember standing at the kitchen sink. I was brushing my teeth, and then that's when I had my cardiac arrest, and I don't have any memory from that all the way until the last day I was in the hospital.
It seemed like it was going to be a normal day that day. I go on in there or go into the bedroom to get her something. When I go in there, it's like, as I'm walking into the door to the bedroom, I hear this big noise, like someone, like a kaboom, So I got on the phone, ran 911. They told me to go ahead and start doing CPR. So they was explaining to me how to do it. And at that same time, my daughter goes ahead and drops down in there and starts doing CPR on her. And it just kind of blew me away. I was ready to hand the phone to her so I could start doing it, and she just jumps right in there. I was really proud of that. I was just shocked, because it was just, I forgot at the time that she took CPR classes, and that made me pretty proud.
They were very surprised that I did as well as I did because, the outcomes usually are not very good at all. I mean, a lot of people die from this.
And what really amazed me is, I took CPR way back when it was kind of like you do the mouth and all that. And this time, when she was saying that on the air or on the phone, I'm thinking to myself, man, they must have changed the way they do CPR, And it didn't dawn on me until later, but it just seems like that's a better way of doing CPR than what they were doing before because you got more chances of getting the blood to the head.
I really want to commend everybody that had their part in it because with them, I would not be alive today. And even though I don't remember it I am so grateful because I'm here to live out my life and be here for my family. Try not to get focused in the everyday things. Enjoy your children, enjoy the people around you, and be able to just carry on and know, and I know this, it was not my time. And there's a reason why I'm still here. So I just want to let everybody know that had a part in it, that I so much appreciate it, because it could have been the other way.
Melissa, to you and your family, thank you so much for sharing your story. Thank you so much. Moving along to our next link in the chain of survival is our fourth chain, which is basic and advanced emergency medical services, where we have the opportunity to continue the resuscitation efforts if not already successfully completed. So it has our opportunity to continue that care and provide that field stabilization and transport to definitive care at our hospitals for these patients. Again, I'll certainly recognize another one of our subject matter experts, and I'd like to invite Dan Chase to come on up as one of our EMS educators and trainers.
Thank you, Chief. I'd like to, first of all, just thank everyone, like we all have, for everyone coming out here tonight. This isn't, something that is done by one person or one organization. This is something that is done by many people in this entire link of chains to help people survive sudden cardiac arrest. So thank you all for coming. It's a special evening to be able to meet some of our patients that, as first responders, I don't often get to meet the patients that we treat in the field and see them after they've survived, especially something like cardiac arrest. So this is pretty special to be able to do that tonight. Once again, my name is Dan Chase, EMS fire instructor for the Eugene Springfield Fire Department. I've been with the department for 10 years. When I started 10 years ago, like we've said before, we did CPR completely different than we do today. We had a lot less responders, less hands to be able to keep doing high quality CPR during the event, and it made for less of a better outcome than we have today. So I'm going to talk about that a little bit. When we first arrive on scene, we want to take over the scene from the bystanders that are hopefully doing CPR. So we check and confirm that the patient is in cardiac arrest. Check a pulse, check if they're breathing, and then we get right on the chest and start doing compressions. At that point, we don't stop compressions until we do have a pulse back. So we rotate our compressors every 2 minutes, make sure that they're fresh and that they're doing high quality CPR. We also place our defibrillation pads on the patient. If they've already been shocked by an AED, we'll replace those pads with ours and see if they are in a shockable rhythm. If they are, then we defibrillate the patient, and if they're not, then we continue CPR and gain intravenous access to be able to give medications that will help prime that heart to be able to start beating again once we give defibrillation. We also breathe for the patient. Obviously, we take over breathing for that patient because they are not. While we're breathing for that patient, we also hook up a monitor that we can tell the cellular metabolism of that patient. And it allows us that when we're doing CPR and we're working a cardiac arrest, that if the patient has a cellular metabolism at the time, we're able to continue resuscitation efforts and hopefully get a return of spontaneous circulation. And we don't ever stop doing resuscitation efforts until we've confirmed that there is no more cellular metabolism going on with that patient, so that we know for sure that we're not going to stop on someone that's still able to be resuscitated. We get vascular access, like I said, give some medications that can help the heart, prime it, get it ready for return of spontaneous circulation. And then once we do get a pulse back, we contact the hospital, let them know that we're bringing in a certain patient. We have things like Pulsera coming out that will allow us to do that sooner. That gets the hospital primed with their cardiac arrest resuscitation team, so when we roll through the doors, they're available to take the patient directly from us. During transport to the hospital, we reassess how the patient's doing. We give certain medications, we give fluids to help with that resuscitation of that patient and to improve the outcome of those patients. So once again, I want to thank all our responders that are here tonight. A lot of them just left to go on a call, but thanks for coming out tonight and all your hard work for what you guys do in the field. So thank you.
Again, we'll take an opportunity to see a survivor's story.
My name is Sandra Simmons. I had cardiac arrest on May 7th at about approximately 10:30 p.m. on a Sunday evening, just after driving my whole family back from Portland. And I just got out of the car, got into the house, and was standing in front of the microwave to put something in there, and everything went gray. And the next thing I knew, 7 hours later, I was being put in a bed in the hospital.
Gigi came in and she found Sandra collapsed in the corner of the kitchen by the microwave, which she was going to work with. And of course, all buttons came loose then at that time for emergency.
They took over as soon as they got in the house from my husband, and my husband was trying to get my daughter to take over from him because of his weak hand, and plus in the position he was in, and she was pretty much in a panic. And so when they came in, they took over and pulled me out into a position where they could work with me, and had to zap me 3 different times to get my heart going, along with doing the compression.
It took a good 3 times with the defibrillator to get her going. And when I was doing it, they were just hooking it up, and I could see by the reading on the defibrillator that she is in total cardiac arrest. And so time was of the essence there.
And I know I was pretty well sedated in the hospital, because for 2 days I hardly remember anything. A couple of visits from a fuzzy doctor, you know, standing up above me, and then the PA, cardiac PA, coming in and getting very close to me and asking me if I knew what happened. And I said, and by then I had been told that I died, and she got in real close and said, "Yes, you died." And it was very interesting how she wanted to make it clear that I understood what happened to me, which I appreciated.
The medical team that came in were really sharp. They knew what it was, they knew what to do, and I was able to give it up without any hard feelings about them not knowing, you know, or having any question about their training, because it was there.
As far as the EMT goes, I truly appreciate their knowledge, their expertise, and knowing what to do when they need to do it, and following through. You know, they saved my life, many other lives. So there's not enough appreciation that, you know, for those people that know how to do that. We take them for granted, I think.
Everybody, from police officers on down to the fire med crew, did everything perfect.
So I was very lucky, very blessed, very lucky, which everybody has reminded me of. All the doctors I've seen, the nurses, and said, I hope you understand how lucky you were. Plus having my husband in the house, knowing what to do, not panicking. And the EMTs were just a few blocks down the street from where we live. And I understand that I set a record for how many vehicles had come to the rescue, I guess. Police cars, ambulances, and whatnot. It kind of filled the street, I guess. Must have been a slow night. So I think we look at life realistically and know that, you know, we only have so many years left, and you try to make the best of it while you're here, and think positive. And I think that's what I've been trying to do. I think I probably even have gotten lazier and don't try to push myself, because I think, I'll get it done tomorrow. So, yeah, and just try to enjoy life and do what you can and enjoy everything as much as you can.
Sandra, again, to you and your family, thank you for sharing your story with us. Moving on to the last link in the chain of survival, advanced life support and post-arrest care. And that involves a lot of what Dan talked about with transitioning or transporting our folks to definitive care. Though we may get them resuscitated in the field, we haven't fixed what caused them to go into cardiac arrest. And typically that's due to some sort of a clot or a blockage in one of their coronary arteries or arteries in their heart. This is a typical day at Riverbend Hospital, where we have our ambulances lined up, but with the systems that we have in place, we have a capability to alert the hospital early and get priority, if you will, of these patients of what's going to happen. Now, interestingly enough, I was like, so what do I talk about when it comes to what happens in this mysterious room up on the 3rd floor, I believe is what it is. And this evening, a gentleman walks in and starts telling me this story about how when he was in nursing school and this and that. I'm like, oh my gosh, what a great story. And I'm like, so who are you? And he goes, oh, well, my name's Harley Anderson, and I'm the manager of the catheterization lab at Riverbend. So tonight, he didn't know it, but I'd like to invite Harley up to maybe tell his story a little bit about what happens up in the catheterization lab and the miracles that transpire up there with him running the facility. I told you.
Yeah, he had no idea I was going to be speaking tonight. Dr. Munkenbach would probably be the better person to be talking about this. Once you get to the cath lab, and these guys do a great job getting patients to us with a chance to make a difference for you. And we have a great crew in our cath lab at Riverbend. We've got a very good mix of long-term technologists, short and younger technologists that have a great opportunity to learn. Dr. Munkenbach has worked with a lot of them. So once we get you to the lab, we gain access to one of two ways, either through the Groin in the femoral artery or through the radial access through the radial. And we're able to go in, put in contrast to see where the blockage is, if there's a blockage, and where it is. And then a lot of times we're able to go in and open that blockage up. And when we do that, it's amazing to see the difference it makes for people. And these guys with the fire department, every one of you, thank you, because y'all give us the chance to be there at that point to make a difference for people. Everyone that got into healthcare, everyone that got into the fire department got in it to help people. And I want to say thanks to the firemen for letting us do that. In the cath lab, the story I actually told him about earlier was actually more of a neuro issue. And when I was in nursing school, I watched the first time I ever saw a carotid stent get put in, which is kind of the same thing that happens with a heart attack patient. You're opening the artery up so that blood will flow. And I saw someone's brain, a lady that was in her 30s, who was confused, and I saw her brain go from looking like a dead tree in her head to a fully blown tree with leaves and everything. I mean, it was just amazing. And within a matter of minutes, this confused lady, who was under sedation, but was still awake enough that she could talk to us, was not confused anymore. And to me, that was one of the most amazing things I'd ever seen. When I see a patient come in that's had a heart attack and we're able to open that artery up, the reasons I got into nursing, the reason these guys got into firefighting, that is the ultimate for us to see that we can make a difference for each of you. And I think the goal once we get you to the hospital is to get that artery, those arteries opened up within 60 minutes from the time you get to the hospital to the time we can get that artery opened up. Last month, our average at Riverbend was 50 minutes, which is very good across the country. I moved here from Texas and the Dallas area, lots of big hospitals and all that. And I'll be the first to tell you, I didn't see better medical care in Dallas, Texas than I see right here in Eugene, Oregon. The paramedics, the fire department, the the doctors at the hospital. It's a first-class place for you to live and have medical care that you deserve.
Thank you, Hurley. Certainly, the miracles never cease. The capacity and capability of not only our first response crews, but the hospital system also continue to improve with time, technology, data, and folks like us in the room who want to make our town, our community, a better place. I'd like to kind of bookend this evening for my portion with that. It's a systems approach. So many times we focus on it was the compressions, or it was the AED, or it was the medications provided by the paramedics, or the airway tube, or the miraculous work in the ER, or the miracles that take place in the cath lab. But this is literally different people from different walks of life who have come together across multiple disciplines to create a very succinct process to go out to folks who are in need, in cardiac arrest. We resuscitate them, we resuscitate our friends, we resuscitate our families, utilize AEDs if there's one out there, and if there isn't, please go out and buy one. Have the advanced life support show up, rapid and definitive transport to a hospital, and take it up to the 3rd floor in the cath lab to get reperfusion, to walk out of the hospital to rejoin their family and continue with their life. And that's certainly a miracle piece when it comes to it. It's not one person. It's absolutely a systems approach. With that, I'd like to invite Chief Zaludik back up.
Thank you, Chief Heppel. Talking about the chain of survival, the things that I'm so impressed that we had 50%. We knew it was hovering around 50. Last I heard it was 48.5. Like, dang, we're so close. But to know that we're at 50%, the best that I know in the country is Seattle, and they're at 51%. So one of the things that happened last year is when we hit the 50% level, we talked to our team and we said, what's the next steps? What's the best service we can imagine we can deliver to this community? And the training staff, especially Karen Anderson, our EMS instructor, she immediately said, I think we're going to take the next steps. We're going to get to 60%. And I was so proud of this team not to be satisfied with 50%. We're going to eventually find ways to get this much closer to 100%. And how we're going to do that is a combination of people and technology. Technology is very important. It is not easy to institute a region-wide application that allows us to get people to the scene. But people continue to work on this every day to make sure this is going to happen in the relative near future. It's not easy to get a system into the hospitals that integrates with our system, and so it's like an IT problem. And having that bring to this community is going to start to improve these numbers. But the thing that's really going to make the biggest difference is going to be the people that get involved. It's going to be the people that jump in and do compression-only CPR, some of them that have been trained by the team right up here in front. And that is what's going to change the delta here. That's what's going to change going from 50% to 60% and beyond. It's going to be people willing to jump in. I am so thankful for the work that was done up at the legislature. We know that every person that graduates from high school is going to have this training. There might be a little gap in years from now until it's institutionalized. Our interest is to look for grants and look for ways to find staff members to put into these schools to make sure we get this training to our community as soon as possible, so everybody leaving our schools has the ability to do this compression-only CPR. I just want to talk a little bit about the professionalism of the men and women of Eugene Springfield Fire that jump in and do this work every single day. I get to do ride-alongs, and I get to observe, I even get to jump in and occasionally do my round of compressions. When you get to a scene, it is the most professional, business-oriented, intensely focused operation you can imagine. We get to the scene with 8, 9, 10 people. It is calm, professional. We have a captain at the head of the individual with a clipboard that is directing the care to make sure things happen in a timely manner. And somebody is doing very rapid compressions, and every 2 minutes they rotate out so a fresh person is in there to do those compressions. I've seen it done in operating rooms. I've seen it done in the field. There is no medical team that is more professional than the people that are delivering this, and that's because of our training department and the adoption of the industry best practices that allow for what's called a pit crew environment to perform these tasks. A pit crew, think of a NASCAR that pulls in and they get their tires changed really fast, very organized, very efficient. This is the kind of work these men and women do every day. I have never been prouder of the way our crews operate in the field as when I see them perform these compressions, specifically if somebody's done bystander CPR, and to see the person get return of circulation and go to the hospital. I got to follow one upstairs, and we got to actually see the reperfusion. And it is miraculous. It is so impressive to see the chain of survival come together. And I think we're just beginning to see some of the efficiencies that we're going to see in the next few years. And we especially are not going to back down from this 60 percentile. So thank you so much for your hard work on that. I just wanted to say we have one more video that we're going to watch today. But something real quick. I don't know if you know I saved this, Karen, but 1 second. These are the score sheets that our crews get when we do compressions. Every person that does compression on that individual, they know the depth and the speed, and they know how that performance is being managed. It's stored in our defibrillator, and then it's printed out later for the training division to evaluate how the compressions went. When I went to the scene one day and I told Karen Anderson where I did CPR, she pulled the chip, she printed it out, she circled what I did, and it says "good job" on there. And so I kept that, right? Because I asked her, how'd I do? I know I did a good job. I was right on the tempo. But to think that we are able to track everybody's performance, that is the attention to detail that it takes by the professionals in this room that are so committed to making sure that everybody has an opportunity to walk out of the hospital like the wonderful survivors we have here today. So again, thank you, crews, and thank you, survivors, for sharing your story. I am so happy with the direction this is going, and I'm going to turn this over to Chief Heppel for the last video, but thank you so much.
I'm Kathleen German. A lot of people call me Kathy.
My name is Stephanie Mayhew, and Kathy has been my caregiver for around 11 or so years.
I've done in-home care. I've done mostly in-home care. And you forget to take care of yourself. I would suggest any caregivers to try and take care of themselves. Even my Dr. Gundry, I go in, have you had a vacation? Have you delegated now some of this work? It was December 18th, and it was during the ice storm, and I had just taken a shower. It happened here at the house.
She managed to take the shower, and she made it out to the couch, and within 10 minutes, I was watching TV and didn't look over, and then within 10 minutes, she was gone.
My friend Stephanie, who's been with me for 11 years, she saw me quit breathing, and then bubbles were coming out of my mouth. She called 911, and they calmed her down. The lady calmed her down. I really appreciate the dispatcher because Stephanie and I are really close.
She instructed me on what to do, and so she instructed me on where to put my hands and everything, and then she just and I said, well, can you count for me? And then she counted for me, and so then I just started doing the compressions, and I did it and did it and did it, and then she instructed me on the whole entire time until the paramedics got here.
The fire department was there, I would say, within 4 minutes to 5 minutes. And she said some big burly guy came over and picked me up and put me on right in the middle of my floor.
And they came right in and took control, and I can't tell you how many were in here. There were so many that came in. They had all the equipment, and they had all the things to get her connected. It was amazing.
Then I was in ICU for 9 days. One of the nurses came out and told one of my sisters that your sister's going to be in there a long, long time. After, I think about 7 days or 8 days, then my son said I squeezed his hand and moved my toe. I remember when my son came in and it was the first time I got up, and I guess I was feisty. I guess when you come off all those medications, you're real feisty. And I was just saying stuff that he goes, is she gonna be like this all the time? When I first got out of the hospital, I thought, home cooking. I went to the kitchen, made myself an egg sandwich immediately, because hospital food I can't stand. Yeah, and plus you get up every day of life and you open the curtains and you enjoy every blade of grass, all the birds, all the trees and the waterfalls, and everything is magnified, and every day is more precious. And that's what I want these EMTs to know, how many people they have made happy. Not just myself, but my son, who almost lost his mom. We've had a wonderful year. This has been just a glorious survival year for us, and we hope we have many more. And for Stephanie, she's like a daughter to me, and it made her happy that I didn't kick the bucket. And then my family, the 9 brothers and sisters, they've all lost all 4 grandparents, and they've also lost both parents. So we grew together, and we're very close. So like I say, they just jumped in here. They drove the rest of their lives driving in ice to get here. And all these people that helped save me, they, I want them to have the happiness that I have gotten, and for their family. And some of them would like to be home right now. They don't like these kind of things, but I appreciate that they're here. And it gives me an opportunity to have some closure of thank you.
Kathy, thank you as well for sharing your story. That was a very poignant, fantastic ending to our evening. I thank everyone for coming this evening and enjoying this event with us. Thank you for everyone who shared this event with us. And we look forward to doing more of these events, hopefully pushing a 60% resuscitation rate into the future. Please travel home safely. Thank you.